13th labs chosen by the New York State Health Department and Governor's Office to do laboratory developed tests. 13 March, a lot happening on Friday the 13th. First patient that we just heard about, the Greyhound driving in his trunk, really didn't drive in his Greyhound drive in his trunk. He said, I took a Greyhound from New York City, made 10 stops away on the way, and then the bus proceeded to Buffalo. 13 March, the second patient in Monroe County tests positive. This is a cafeteria worker in Arcadia Middle School in Greece. This patient has no known connection to the index patient, no history of travel, no history of exposure to a prior confirmed case. So this is assumed or presumed to be the first case of community onset COVID in Monroe County. The same day, the county declares a state of emergency. Also on that same day, all reagents were sold to Quest and LabCorp in anticipation of those guys being the reference labs, making the platform that a lot of hospitals were using, this Roche platform, no longer supportable to do testing for local laboratories. On 7 March, the CDC issues its first change to the guidance of the management of exposed healthcare workers. A day later, the Department of Health in New York State supersedes the CDC guidelines regarding medium risk exposures. On 14 March, RGH opens up and begins to process lab samples. 16 March, the Department of Health issues another change in the management of exposed healthcare workers, and this pertains to management letting high-risk healthcare workers work. On 21 March, an occupational health department was expanded and began to assume tracking and management of exposed healthcare workers. And on 24 March, RRH noted its 45th confirmed case of COVID and had 16 patients in the hospital and 10 to 11 in the ICU. On the 16th March also, we had through the system, formal recommendations were issued, and they were finalized and posted on the toolkit for the guidance of personal protective equipment. On or about 16 March, commercial testing was expected to become widely available. Again, the demand quickly outstrips capacity. Currently, there's a turnaround time from those labs of almost more than a week. And as of 24 March, approximately only 70 of over 400 tests had been resulted. 18 March, movie theaters, gyms, restaurants, and bars are closed in New York. 19 March, all places of public amusement are closed. And then on 20 March, the New York City Department of Health, and later similarly, more widely, outpatient testing must not be encouraged, promoted, or advertised. And so I think given this background, you can see why, if you called for a Vice one day and then you called for a device 2 or 3 days later, you might have been given a different message. So what is going on currently? So as of, to give you the latest, we had to stop at a certain time. And so as of 24 March in Monroe County, you can read the numbers there. There were about 1,500 cases that tested. Of those, 106 confirmed, 15 in the hospital, and 3 deaths. This is Monroe County. And you could see the age distribution there. I mean, it's pretty consistent whether or not you're 20 to 29 or 60 to 69. As of 25th March, that updated to 117 cases, 22 in the hospital, 11 of those in the ICU, and 3 deaths. 2 people have resolved and have been released from isolation. And currently, there were about 530 some people on mandatory quarantine and isolation. So how about a snapshot of the laboratory? So as of 24 or 25, RRH had 736 tests performed. 53 were positive for an overall positivity rate of 7.2%. And then how are we looking across the system? Well, as of the 23rd of March, unfortunately, every hospital in the system had a case of COVID. And you could see the breakdown there. Most are at RGH and Unity, but no hospital has been spared. on the average, we were looking at an increase of 2 inpatients a day, and on Monday, the incident command predicted that we'd have 25 patients in the house by Friday, and I think we're a little bit above that right now. So how about the cohort? As of 23 March, we had 44 positives, and you can see the breakdown. 24 male, mean age 58. The age ranged from 21 to 94. 7 of those were healthcare workers. A 55% hospitalization rate, with almost a third requiring ICU and 2 deaths. Now, it's important to point out that the mean length of stay here is 5.8 is an underestimate, because a lot of the people are still in the hospital, but we had at the date the lockdown day for this analysis, so it's going to be a little longer. If you look at the people who were actually discharged from the hospital, the average length of stay was 6.5 days. 6.3 days spent in the ICU. Also an underestimate, because a lot of them are still in the ICU. About 43% smoked, half never smoked, and 1 unknown. When we broke it down kind of from between all comers, those in the hospital and those in the ICU. 17 as of 25 March, 22 in the hospital. 11 of the, almost half of the patients that were in the hospital needed the ICU. There were 3 deaths. So far, there's 534 people into mandatory quarantine and isolation. Here's a snapshot of the lab at RGH. As of the 25th, RGH had 736 tests resulted, and an overall positivity rate of 7.2%. Well, across the country, it's about 10%, and in high areas like New York City, it's higher than that. And I think we're seeing an increase. If you talk to the people who are doing the tests, they're seeing an increase in the number of positives, the proportion of positives every day. Breakdown across the system of confirmed cases now shows that every hospital has had a confirmed case, and mostly at RGH and Unity. You can see the color breakdown there. On Monday, we predicted that the incident command predicted an increase of 2 patients per day, such that by Friday, tomorrow, there'd be 25 patients in the house, and I think we're at that now already. If we look at the cohort itself, it included 44 patients, and this data is up to 23 March. 24 of them were male. The mean age, you can see 58, range there. 7 were healthcare workers. A little over half required hospitalization, and a little less than a third required ICU. We had 2 deaths. The mean length of stay is about 5.8, but that's an underestimate, because some people are still in the hospital. That was the mean length of stay when we stopped the analysis on 23 March. Of those that were DC'd, the mean length of stay is 6.5. And that's pretty consistent with some of the modeling that we'll see later, the numbers that we put in there. In the ICU, the mean length of stay was 6.3, but that's an underestimate as well. Half of the people never smoked. 77% of the people that needed ICU.
Just 1 minute. People on the audience, if you're not speaking, please mute your microphone, because we're still hearing background conversation. Thank you.
So, as kind of was expected, over half of the people had comorbidities, and 77% of the people that needed ICU treatment had comorbidities. If you look at the mean number of healthcare workers that were exposed for every new case, overall, all comers, inpatient and outpatient, it was about 6.5 healthcare workers per case. If you just look at the inpatient number, it was about 12. Most of that is skewed by the first 2 cases at both hospitals, and we had a quite bad number of exposures, up to 101. And at the time, the average time from isolation, knowing that the patient was 17 days. Currently, most hospitals are having 0 minutes of time to isolation at this point. So that's some good news. As of 23, these were the most common presenting symptoms in our cohort. So all combined, 91% had fever. Of the people that needed hospital, 92%. And you can pretty much see the breakdown there. So you have fever, shortness of breath, cough, malaise. People are seeing syncope or falls as not an uncommon reason for admission, and either nausea or diarrhea in over a third of them. It looks like shortness of breath, a little more common in, I don't think, you can make any conclusions, but people that needed ICU were more short of breath, or more frequently short of breath. So how about imaging? So we looked at the imaging, and just with the limited amount of time we had, we looked at a normal or any type of consolidation. 78% of the patients of the diagnosis had any type of consolidation, and 83% of these were at any time in their healthcare record, any time of the period that we were looking at, and 63% had an abnormal chest X-ray at admission. Of the people in the ICU, 100% had an abnormal chest X-ray at any given time, and over 3/4 of those had an abnormal chest X-ray with any consolidation on the day of admission. For CT scans, small number of cases, I think only 10 people had CT scans initially, and but most were abnormal. There were in people that were hospitalized and needed ICU, there were no normal CT scans. Most people were mildly lymphocytic. The mean lymphocyte count was 1, and you could read the mean lymphocyte percent there as 15. And in the ICU, the mean count in percent was slightly lower. When we look at all comers versus those who needed ICUs, there was really no appreciable difference between AST, ALT, ferritin, fibrinogen, and LDH. All were pretty similar. The CRP was a little higher in those that went in the ICU, and at this time, people were not widely ordering D-dimers, so we only have a few, and I don't know what you can conclude there yet. So a quick look at this altogether, we could not yet glean any predictive markers. Now, it's important, we have some very important limitations and caveats here. Not all of these data points are available for all the patients yet. And I would draw your attention to a very helpful floor management plan by Dr. Shepard and everybody that suggests some approaches for some lab. You might also consider ordering an IL-6, but at currently I think it has a pretty long turnaround time. A D-dimer and a CRP and all would add to the robustness of some of the conclusions we might be able to draw. We're going to relook at this same cohort when we hit 100 patients, and at the current rate, that's probably going to be by the end of next week, unfortunately. How were most of these patients treated, or how were they? We have treatment data for all of them. Most of them needed supplemental oxygen if they were admitted. 4 were given steroids, 10 hydroxychloroquine, 2 Kaletra, and as of so far, none had anti-IL-6 inhibitors. So that's what we see. What can we expect? So when you look at modeling projections, you can use at least 5 different ones that are all probably equally robust. And the incident command team looked at all of these basically. So if you look at the Harvard University, that's primarily weighted towards China. And it breaks down rate of infection, attack rates between 20, 40, and 60%. And it's a 3x3 scenario, so 9 separate scenarios. So you have a higher attack rate, or you don't flatten the curve. So not flattening curve is the 6-month parameter, and 8 months is hoping that you're doing social distancing and it had some effect. The Imperial College was also used in the RRH analysis, and that was primarily used, and that's based on cases seen in Great Britain. It takes into account that most people spend 8 to 10 days on a med-surg floor and 10 days on an ICU, and you could see the assumptions there. And so, but if you want to go into the details about Johns Hopkins, you can see their parameters. And the parameter that they use, they're talking about 33% requiring an ICU level of care. That's what we saw already in our small little cohort. And they're using about a 1 to a 3% mortality rate. Penn University has their own little calculator. RH actually uses some of that, as you'll see, with including market share, etc. and then the University of Nebraska. But going back to the pen, they have a little calculator there, so you put your numbers there in a calculator, and it gives you a curve of what you can expect in your hospital or your healthcare system. So what do we do at the RRH? So they took a breakdown of the county based on 2018 census, and they looked across the 13 county primary service area. And they used the Harvard thing of the 20, 40, and 60% scenarios. And they also combined some factors with the Imperial College. And they also realized that not everybody in Monroe County is going to come to RRH, right? So there's university hospitals in the system. And so how to best control or adjust for that is they look at the market share. Over a usual year or 2 years, how many people in the county, in the 13 county area, go to an RRH facility. So you put all of that in to the sausage maker, and these are the parameters that were used. And this is what comes out. But before I show you what came out, you have to a couple of important considerations. So our hospital, if you walked on 2000, you'll see it's pretty much empty. So the modeling that is used is already starts at this vacated level. Most of the time we're at capacity or we're slightly over capacity. These projections are using models that were very reduced. We're not very reduced, but kind of where we are now, at anywhere from in outlying hospitals 60% capacity to here at RGH only 80% capacity. The Imperial College, most of the parameters were used from there. That results in a potential underestimation of the impact. And Patrick Brodie and Donna Newhart say that if we used Harvard model completely, the numbers would be much worse. So what are they? So if you look at it, you can see in the color, that shows you what happens, what type of curve you're looking at. The 6-month curve is in the orange. That's the worst case scenario. And if you can flatten that as much as possible with the social distancing, etc., that's the light yellow color. And then the gray is middle of the road. You then look at on the other axis there, it's just the percent, or the attack rate, the percent infected. And so you can see the one in the upper left, available hospital beds. The red dotted line is our average current capacity. That's the capacity. So you could see how far above the capacity we would be. And you can see total ventilators or ICU spaces needed over there. Over a 6-month period at a 20% infection rate, you're talking about 200 or so additional ventilators. And so with that, I'd like to thank the IP, the ID, the lab group, every Incident Command, Ken Turner, and everybody else. And I'm going to turn it, before we go for questions, Dr. Laggio is here. She's going to talk about treatment and briefly, or help me answer questions. And then I expect, hopefully, Jennifer Gutowski will come up and also help answer some of your questions.
And I hope that you can hear me okay, and forgive that I don't have any slides. But I would just like to underscore that as amazing as this time is now, we really need to remember some of our basic principles of being doctors, that we really first need to do no harm. And we need to rely on sound medical evidence. And what we've used mostly to treat serious respiratory viral infections is supportive care. Can you hear me okay? Oh, so I wanted to stress that supportive care remains the backbone of therapy. I really commend our pulmonary docs for being able to consolidate a tremendous amount of supportive care measures into a single document for guidance for our providers. Because currently as it is, we do not have any strong evidence to support a specific antiviral or an immunomodulatory medication. There's a lot of things that are floating out there in the Twitterverse, on other forms of media, and looking at some of the protocols from major centers as well as other countries in the world who are dealing with the current pandemic, there's a lot of variability, and we have taken it very seriously to try and appraise the evidence as it stands and try and create a sound guidance for what we can use for our patients here. So I'm going to briefly talk about some medications, and again, I'm sorry I don't have slides so you could just see the names of some of these medicines, but I'm going to go through a few that you've probably heard and really just kind of highlight like what we know about them and where they stand for our ability to use them for our patients here. So the first I'm going to talk about is the antiviral called remdesivir. Now, this has been developed during the response to the Ebola outbreak in West Africa in 2014-2015, and it specifically is an inhibitor of the RNA polymerase of at least SARS-CoV-1. And we are still awaiting actual efficacy data for the Ebola outbreak. In terms of SARS-CoV-2, there is suggestions that there is in vitro activity against the virus, but as other medications, sometimes we just need to caution that in vitro therapy does not always translate to clinical efficacy. Currently, in the U.S., there are 4 clinical trials that are ongoing that institutions could be a part of and get the medication in a placebo-controlled fashion. In town, the U of R will be a site for one of those, and we are working with our group to see if we can also become a site over here. Prior to this last Sunday, there was an opportunity for compassionate use of this medication for severely ill, mechanically vented COVID-positive patients. The process was application through Gilead and then approval through the FDA. The company had become so overwhelmed with so many applications that they had to stop and limit compassionate use moving forward, and it's limited now only to the severely ill pregnant, and the severely ill and those who are less than 18 years old. So at this time, we're still investigating would we be able to participate in a clinical trial to be here. But if that were, it probably wouldn't be for several weeks. The other medication which has gotten a lot of attention is chloroquine and hydroxychloroquine. Now, these are traditionally anti-malarials and anti-inflammatory medications with its potential purported antiviral action is that it can change the pH of cells and in some ways prohibit viral fusion and some of the viral activities in cells. You know, we have a long-standing experience with this medicine, and the antiviral properties have been discovered even in the 60s and 70s, but it really only hasn't come to light until now. In terms of specific efficacy data that we have for this medication, it started with a report out of China early in the epidemic of 100 patients it was not a controlled study, and they may have had better clinical outcomes. There are other reports that it may also be associated with decreased duration of viral shedding, but that isn't always a great correlate of what is the duration of symptoms or severity of illness. Many other protocols, such as Mass Gen, Cleveland, UCSF, UW, they all include hydroxychloroquine on them. Now, when we developed our guidelines that are in the toolkit, it is included for people who are symptomatic with evidence of lower tract disease. As of now, 2 days ago, Governor Cuomo, in his executive order, included a clause that had noted that no hydroxychloroquine or chloroquine can be dispensed from a pharmacy without an FDA-approved indication, or it is involving a scenario in which is a state-approved clinical trial. Now, COVID-19 is not an FDA-approved indication for hydroxychloroquine, and in communications with the local and state health departments, we are still awaiting guidance on what they mean about a New York State approved clinical trial. Preliminary information that we've received from them is that answers are forthcoming, and the interpretation, at least now, is because the state has stockpiles of it, if you needed to use it, they would want that patient information. So we just have to clarify really what that means for us. We have a very limited supply, and having this executive order come out in the middle of some patients on treatment really created an ethical snafu. But we've decided that we are continuing the therapy of those who've already started on treatment, but we are holding on initiating any new therapies until we have further guidance from the state and our pharmacy colleagues of what the best thing to do is. Two other medicines that are purported to have effectiveness in this scenario is one is an HIV medication. The brand name is Kaletra. It's also called, the generic name is lopinavir ritonavir. It's a protease inhibitor with a second protease inhibitor that actually kind of boosts its levels. So we have a lot of experience with using this with HIV infected patients, and due to the similarities of its protein inhibition with the SARS-CoV-2 virus, it has been suggested that it may be effective. Last week in NEJM, there was a actual trial examining its use in China early in the epidemic. There was an open label trial of Kaletra versus standard of care. The study could be powered if they enrolled 160 people. The investigators decided that since at that time there were so many patients that were eligible, they actually enrolled 199. And they decided to stop the trial at that point because then remdesivir was becoming available. But in their analysis of those 199 patients, 100 of which got standard of care, and the mean duration of symptomatology at the time of enrollment was around 13 days. A third of them were mechanically ventilated. Part of the criteria was to have hypoxia and lower tract disease. The conclusions from this study were that Kaletra did not have any statistically significant differences in outcomes, whether it was length of stay or death or duration on the vent. But if you look at the actual numbers, the numerical numbers, and one thing that we look at in this study is, well, maybe these patients were started on an antiviral too late. 13 days is a long time to be infected, and considering the other general tenets of infectious disease, that early initiation of therapy is probably better, and we know that it can be advantageous to try and prevent the extent of the disease and reduce severity. Our question is, well, maybe if we're not able to get remdesivir and hydroxychloroquine is unavailable, could Kaletra be something used in the appropriately chosen population, those particularly who are presenting with symptoms that are less than 7 days? So this is something that we've talked about with our groups in pulmonary, that potentially, because we do have patients who are presenting early, is this an option in addition to standard of care? A similar HIV medication that has also been circulated on other protocols is Prescobix, and it also involves a protease inhibitor called darunavir. Last medicine I'm gonna mention here is an IL-6 inhibitor called tocilizumab. The rationale behind considering use of tocilizumab is that in the course of this severe viral pneumonia, is there a cytokine storm which hastens worse outcomes? There is the current evidence that we have now, although it makes rational sense, is one study that was 21 patients in China in one hospital that was not compared to any control group. And it's essentially a case series description of acceptable outcomes for individuals who got tocilizumab, in addition to they were also given Kaletra and other antivirals and their standard of care. So that's the evidence basis that we stand on for this. We think it makes rational sense, but I think it probably is something that we need to consider in a select group of individuals. There is a clinical trial of the use of tocilizumab that would be placebo-controlled, that would be through Roche, their drug company, and we have submitted an application to also be a site to participate in that clinical trial for this med. And then last comments for other medications to note that we included on our treatment guidelines. I'm sure many of you have probably wondered about the role of steroids or NSAIDs or ACEs and ARBs or statins. And currently, we think, and many other protocols also say that, the role of steroids is very controversial, and similar to other viral pandemics, corticosteroids may be associated with worsening of the viral-associated lung injury. So we advise that steroids should only be used if there is an alternative clinical condition that actually warrants their use, such as COPD, etc. Regarding NSAIDs, the root of the thought that NSAIDs may be associated with clinical deterioration for some COVID patients, there's no high quality evidence of that. The root of that was a 4-patient observation of some physicians in France that became tweeted by the Ministry of Health there and became spread as well. So we don't think that there's a strong evidence basis to necessarily avoid NSAIDs, but we think that, if you need a something for an antipyretic or pain, then maximize your other agents if possible. In terms of ACEs and ARBs, there has been discussion over how the ACE inhibitor receptor is present in the lungs, and does that have any role in progression of viral disease? Again, this is all hypothetical, and we as a group have said, we do not recommend starting or stopping anyone's ACE or ARB as it relates to the treatment of COVID. If they are on it, then continue it. They have other justifiable medical reasons for it. There's no reason to stop it. But if they don't have a reason to do it, to have an ACE or ARB, we don't recommend starting it. And then last would be statins. Some protocols have included the detail that statins may have some anti-inflammatory opportunity. But for us, our groups, we are not recommending starting a statin if a patient is not on it. If they are already on a statin, to continue the same medication. But overall, I think regarding these other non-antiviral medications, we need to be very cautious. And really, I'd say, remember, our first thing is we should not do any harm. And with that, I'm going to hand it over to Jen Krakowski.
Yeah, we're going to take we got some questions in. Thank you, Dr. Laggio. That was wonderful. Can everybody still hear us? While you guys prepare your other questions, I got a list of questions here. I have Jennifer Gutowski, Associate Director of Infection Prevention for RRH, and also Jennifer James, one of our key partners also in infection control. And so I'll read the first question. I understand that the most common spread is through infected secretions that aerosolize through cough or sneezing, or through fomites. How does an asymptomatic carrier then transmit the disease if they are not coughing or sneezing? I'll take the easy ones, and I'm going to give the hard ones to Jennifer and Jennifer. So it's correct that the most common spread is through droplet secretions, through coughing, larger particles that hang around in the air for a little bit, and then settle on the ground or end up on your hand, that then go on fomites and then back in people's mucous membranes. Increasingly, I think there are reports of asymptomatic transmission, and I think colleagues of Dr. Walsh and Falsey, who are heavily studying this in Washington State, to include pediatrics, asymptomatic pediatrics, there's some evidence there that children are also important carriers, and so they'd probably spread it the same way, except that they're not coughing and sneezing and febrile as much. I mean, everybody coughs or sneezes or once in a while, so the transmission. Do you agree?
Yeah, they're not. And if they're touching their eyes and nose and mouth and touching other things, I think fomites are still a concern. So I would say if they're asymptomatic, contact is even more of a concern, that they would be touching their own mucous membranes and touching other people or things without washing their hands.
So the next question is, does the virus aerosolize and hang around in the air for minutes to hours? Can the mode of infection be because the virus is airborne? Now that's a great question, and a lot of that concern is driven by a correspondence in a New England Journal of Medicine article that we have, fortunately, the expertise through Dr. Walsh and Dr. Laggio and the whole team here to answer with a high degree of mathematical precision. So first, the easy part of that is, if the virus were primarily aerosolized transmitted, the R naught would be a lot higher than even if you give it a 4. It would be like tuberculosis, and we would see a lot more cases. So epidemiologically, it doesn't look that way. But what the New England Journal authors pointed out was that if you stick a level of virus, a concentration of virus that's presumed to be analogous to the dose in a sick patient that's coughing, and you stick that in a special high-powered aerosolizer, highly efficient aerosolizer, and then you created a fog, and then you extracted that, and you looked for detectable viral genetic material in that fog, you would find it. But Dr. Walsh calculated that, so that it's important to note that particular aerosolizer that they use, the Collison 3 jet nebulizer, produces about 1 times 10 to the 12th infectious particles, whereas if you're in a room, a standard size room, a hospital room with a patient, and you use typical human tidal volumes, and you use the same dose, the amount of virus in the air would be magnitudes less, somewhere less than 1,000, and you'd further reduce that if you had a simple surgical mask on. So we don't think the virus is predominantly aerosolized, and that is reflected in the guidance from the CDC and the state health departments for PPE. Then given the next question is, given that healthcare providers are at high risk of infection, should we not make testing more widely available to healthcare workers who develop symptoms? Are we putting healthcare workers at risk? Well, I think we all agree that one of the biggest problems here is the limited amount of testing. And of course, we would, in all of our testing algorithms or testing recommendations, healthcare workers are always given high priority. But the capacity was so bad is that we had to prioritize our priorities. And so I don't think we're putting healthcare workers at risk by not testing them, although it would be much better if we could test all the people we need to test. Because no matter what revision of the exposed healthcare worker you look at, the main thing is symptomatic. So if you are symptomatic, we ask that you don't come to work. If you have symptoms, you don't come to work. If you're exposed, even under a high-risk exposure now, that was the latest change, you can still work as long as you wear a mask and you're not symptomatic. Now, we may be, I'm sure we're probably risking spreading the virus. Would we have the ability to furlough every healthcare worker anyway is a question I would ask. So the next question is, if we don't, holy cow, Okay, I got to go fast now because the questions are pouring in. If we don't have enough PPE, should they be risking their life if it's not available? I know we get a lot of concern and a lot of questions about that. And our recommendations are always driven by safety. And they're always informed on the CDC guidelines, the latest CDC guidelines and the Department of Health guidelines. We have enough PPE, so they're not safe use, and I emphasize the term safe use, is not driven by supply constraints. What supply constraints drive is our sensitivity to preserve all the PPE that we can through wise use. So we really want to discourage the use that it has not been proven most effective or even can prove harmful. So we have, throughout the system, people track our burn rates and our issuance rates every day, and we that said, to my knowledge, and those are cause for concern. I'm sure you heard Governor Cuomo say this morning that every hospital has enough PPE right now, and that's true. But depending on the day and depending on how many exposures, our burn rate is dramatically different from day to day. And there are times when we look at it and we're down to having less than a couple days on supply. And so that's why we're saying we want to preserve all the safety equipment, the PPE, for the most high-risk procedures and for the healthcare workers that need the most. But I would encourage you to reach out to your politicians and say, pressure the federal government to launch the Defense Production Act to get them to make more. Mitigation, another question. Mitigation requires far and wide testing. How will we identify those infected and the clusters that result from the infected? Who should be quarantined if we don't test widely? Again, we would love to test widely. We can't. Germany shows that early testing and effective quarantine has kept their death rate pretty low. I guess that was a comment.
And Dr. Lesho, the only thing about the fact that we're not testing doesn't mean we're not excluding as if they were positive. So right now, if someone who has contact with COVID does have a fever or symptoms, they are asked to stay out for the same amount of time as if they tested positive. So we are hoping to still contain the spread in that respect.
Getting only random bonks. I can see the slides now. Tones constantly. Okay, here we go. Can't see you. We have been. I'm looking at some other questions here. All right.
Can I ask a related one? So somebody who got sent home because they had symptoms and possible exposure, their symptoms rapidly cleared. Do they still need to stay out for 14 days?
I'm going to let
So if they have symptoms, we are now saying that they need to stay out for at least 7 days. And then if they're fever, and so at least 7 days and at least 3 days after the last fever and symptoms need to be improving. So if they still had a fever at day 6, they still need 3 days beyond that last fever. So we are going with CDC guidance for that. If they were a contact to a confirmed COVID case, we would ask that they, even if they're coming back to work at day 8, they need to still wear a mask until day 14.
Another question, can you speak about introducing people who have been ill? I've heard various models of immune response. Yes, I mean, we are. Once we don't know a lot about immunity. The virologists say that it might be more slowly to develop than other ones. But yeah, absolutely. We would look at those people are brought back into the workforce. Are they considered immune? Perhaps, maybe. The hypothesis is that they would be good candidates to have on, the COVID strike force teams, but too early in this disease situation to know the exact immune response yet. Current supportive respiratory care, managed COPD exacerbation. Ethical question, what are your thoughts on CPR in patients with COVID who arrest? Does that expose providers to high-risk exposure? Well, So if you're doing an aerosol generating procedure, we call them AGPs, the recommendation is that you should have an N95 mask. In a COVID situation, it's unlikely that you're going to have ready access to an N95 mask. And if you have to intubate and there's a lot of secretions and suction, you could. But you're right. That's an ethical question. And I know Dr. Reynolds and his team meet regularly to discuss such questions. But towards conserving PPE, what I would ask people to do is when you have patients that are placed on comfort care measures, or their care is de-escalated because they're approaching, sadly, their terminal state, consider minimizing, going in and out of the room and all unnecessary procedures and visits, so that we can use that to also try to preserve PPE until we get more supplies. What is the sensitivity of the COVID test? In the outpatient setting, we see a couple of symptomatic patients with known positive household contacts who have tested negative. Do we assume false negative in those cases and treat as if it's COVID? I can't really speak too much to that. I know there are certain constraints where, unlike a normal assay, we can't get specific sensitivity and specificity in PPV and NPV because of the limited or lack of defined positive and negative controls, etc. But that said, it's pretty good. I mean, all the tests before they're released undergo at least a 4, if not a 6-eyed review. To include mostly by Dr. Vargas and Dr. Walsh. And when there are tests that the thermocycler behaves such that it comes up too late, that suggests that too much amplification, that suggests it might be a weak positive. The mechanisms are put in place to keep that test as pending until it's repeated. So I think we have pretty great performance so far on the test.
Yeah.
If I could add to that, as in any other test, your sensitivity and specificity are contingent on your pre-test probability. So looking at the internal workings of ID here, any time that any of these tests have come out, we evaluate the record to see whether or not it actually would be consistent with our other COVID patients. And for the vast majority, you can never say 100%, but pretty dang close. When we see a positive test, it is a very consistent clinical picture. Now, it is challenging, but I think also the epidemiologic history is very important. So if you do have a test that seems negative in somebody with a household positive COVID, you do need to continue to exhibit extreme precaution.
Yeah, from IP, we would still recommend that you isolate that individual for the 14-day quarantine period, especially if they're symptomatic.
Yeah, two very important points by Jennifer Gutowski and Dr. Lagio. Continue to isolate, yes. I guess the short-winded answer that I should have said was yes, consider it a false negative. Here's a good question I definitely have to address because it comes up all the time. It has been reported that in South Korea, in-hospital transmission and healthcare worker infection has been controlled by a strict protocol that includes surgical masks for workers upon entering the facility and for the duration of the shift. Why are we not imposing this protocol here? We are attempting to do that. The one reason is that our supply on hand at any given time would not fully support that, and there are downsides to that. And so when you look at an interventional study across, it's very difficult to say, was the fact that everybody was given a mask in South Korea or Indonesia, what about all the other components of their response? We don't know that it was just the mask that did that. It could have been it could have been many other things. But also there's a downside. And initially, infection control was a little bit hesitant about this because you have to be careful that you're not creating a false sense of security and also making it easy for you to self-contaminate or infect yourself by causing you to touch your face more. And it's especially, you have to be especially careful that if you go into a patient's room who is already on droplet or contact precautions, that ideally you should change that mask as you normally would when you come out of that room. Now that, and when you walk across the hallway, you'll see people in various masks, and you see them in various positions on their face. And most of them are not correct, or, you know, so you have to be careful. And I know that our colleagues across the way at Strong have issued a mask that way, or have adopted that policy. We are in the process of trying to take it one step further, well, where not only will we be able to issue somebody a mask every day, and we want to make it point out that that is not your only mask. That's the one mask a day. So if you if you go into a heavily contaminated room and you're touching patients, of course you're going to change that mask and you're going to get another mask. So we don't want to cause a misperception that that's the only mask you're going to get. But we're also in the process of attempting to get everybody a face shield that would increase the duration of that mask, the lifespan, so that in addition to wearing that mask every day, you're also going to have your own face shield to wear every day. And the contracts are being written and the productions are hopefully being in place. All right, almost done with the last question. If hydroxychloroquine may lead to viral clearance therapy rationale in using it in patients who are symptomatic to reduce transmission. Do you understand that question from Nagash?
So if the hydroxychloroquine may lead to viral clearance therapy rationale, is there rationale in using it in patients who are symptomatic to reduce transmission? Well, I think in an ideal situation where there is an abundance of supply, then we can talk about using any medication for prevention, chemoprophylaxis. You know, there are randomized trials on clinicaltrials.gov that are trying to look and see if prescription of hydroxychloroquine to those at risk, like healthcare workers, can minimize the chance of infection. I can see how there's a rationale there, but I think that there are significant cons to it. One would be the supply, as I mentioned, and two, none of these medications are without risk. And there are many times in which we see that we don't know exactly what the best dose is. What's the safe dose? What's the rational dose? What's the duration? So I think this really stresses that, you know, we're all smart people and we can make some conclusions of how things should work in the world, but we need clinical trials to actually get us data and we can learn from these things. And so we have a more informed workforce for the next pandemic.
All right, thank you. An important clarification from Palliative Care Group. I don't know if you can see the conversation, but Dr. Herman comments that you cannot provide less care based on code status. And then another related question, why not just mask all patients one a day may decrease the burn rate actually? Well, initially, although it may decrease your personal burn rate, if other people who really don't even need a mask or are not having patient contact that much yet earlier on, you're actually increasing overall burn rate. But again, we addressed that earlier. Are we seeing a lot? Do we know the person who rode to Buffalo? Do we know how much he seeded along the way? I don't know that. Maybe the health department does and is not releasing that, but I don't know that. Are we seeing loss of taste and smell as a symptom, as has been reported elsewhere? By the time that was reported, we had already been collecting the data, and unfortunately, we weren't looking at that. We're going to try to look at that in the future. I don't know. How safe are, here's a good question, how safe are cloth masks compared to surgical masks? So I want to dispel some rumors here. When you hear cloth masks are not recommended, and we're not recommending that, except in a period of extreme desperation. I guess it's better than nothing. But when you hear the report that Hickey Freeman is making masks for the system, although they are cloth masks, they are special cloth masks, and that cloth is being taken from the cloth that surgical instruments are wrapped in when they're sterilized. So the surgical wrap, and that has a higher filtration rate. So it's important to make that distinction. And that relates to, do we know anything regarding the efficacy of the cloth masks from Hickey Freeman? No. What they might be used for is a second choice if we really get constrained on the surgical or the loop masks. That's where and I think everybody, that's the last question, and we're only 4 minutes. Wait, overtime. Are those cloth masks washable? There are discussions, yes, that we would reprocess them in sterile processing. So yes, they are washable.
So thank you very much, everybody. I think we're a couple of minutes over time, but I think we got a lot of questions answered. I think we are going to need to do this kind of thing relatively frequently because people have lots of questions and there are new ones emerging. So I don't know if it's every other week or every week initially. We will try to have these so people can get their questions answered. I think it helps allay anxiety and allows people to work in a rational frame because there's so much different information coming on this. It's hard to sort out the real stuff from the facts. And so I think you guys were great at doing this. Thank you very much, and talk again soon.
All right, thanks everybody.